Hi, my name is Mary Vukicevic and this presentation is about ocular tumours. Ocular tumours can occur pretty much anywhere in the eye, as you can see in this slide here. So they can appear in the iris, the ciliary body, the choroid, the retina, and the retinal pigment epithelium. And I've divided all the different types of tumours under the particular eye structure that they affect. So in this presentation, I'm going to tell you about those tumours that you are most likely to see clinically, and the presentation will be ordered according to the tumour type, irrespective of where it is in the eye, where it occurs, in what structure. So for example, if I'm talking about nevi can be found in the iris and they can also be found in the choroid. So as a whole, I'll tell you about nevi generally. And then melanomas can be found in the ciliary body and the choroid and the iris, and I'll tell you about melanomas in one section. So this is how the presentation will be structured. So let's start by having a look at nevi, or nevi is the plural for nevis. And we'll have a look first at nevi that occur in the iris. They can also occur in the choroid. So an iris nevis is a pigmented, flat, or sometimes slightly elevated tumour, and it's usually less than 3 millimeters in diameter, so very small. What it does is it disrupts the structure of the iris and can cause distortion of the pupil. In the image at the top there, you can see a brown area, which is the iris nevis. It's just here, and you can see that the nevis is pulling this pupil slightly out of shape. So this is where the disruption of the iris is occurring in this particular nevis. In this image below, we've got a choroidal nevis, and a choroidal nevis is fairly common. You will see these clinically. They are present in about 5 to 10% of Caucasians, and usually they are present at birth, but they do grow a little bit before puberty. And often the patient doesn't have any symptoms, and it's just detected on a routine examination. So what you will see is a very typical oval type shape, and it's usually a slate color or a gray lesion. And it has what we call detectable but not sharp borders. So if you were to take a pencil and try and draw exactly around this nevis, you would have some difficulty actually defining the edge. Now, what you need to notice in this image here is that the retinal vessels run over the nevis. You can see the retinal vessels here. And it's because these retinal vessels are more forward than the nevis. The nevis is down in the choroid, so you know it's actually under the retinal vessels. What you can also notice is with the nevis, it's not distorting the shape of the retina or those vessels. They are just continuing their normal course. We will now have a look at melanomas, and we'll start by observing iris melanomas. These can be either pigmented or not pigmented. So here they are. This is a pigmented iris melanoma, and this one here is a non-pigmented one. And they can usually be seen in the inferior section of the iris area. They're usually about 3 millimeters in diameter and approximately a millimeter thick, so they are very small. Now, they can also distort the pupil, just like an iris nevis can. They are quite common, or people with fair skin, I should say, are more predisposed to having iris melanomas, and the light iris color in fair skin people puts them at greater risk of developing either an iris or a uveal melanoma. Of all uveal melanomas, 3% of those will arise in the iris. So usually they have a good prognosis. However, about 5% of people who have an iris melanoma will develop a metastases within 10 years. So unfortunately that will spread through other structures of the body. So the patient will usually come in their 50s or their 60s, and they will complain that they've got an iris lesion that is getting bigger over time. Sometimes the melanoma can also grow along the iris surface and can invade the angle, and this is what's happening here. So here we've got the cornea, and the iris angle has been invaded, or the angle of the anterior chamber rather has been invaded by that melanoma. This melanoma here is found in the ciliary body, and you can see it on the image here. We've got the pupil in blue, and then you're looking through the the iris in blue, and you're looking through the pupil, and you can see the melanoma just there, that this yellowy orange colored structure, and it's sitting in the ciliary body. So 5% of all uveal melanomas arise in the ciliary body, and a patient will attend usually in their 60s, and they will complain of having reduced visual acuity. And you can have a look in the eye and see very large tumours, but sometimes smaller tumours are going to need pupil dilation in order to view them, and gonioscopy rather than just with fundoscopy. Occasionally the melanoma can also be discovered on routine examination if the patient's just going in for an eye check with their eye specialist or optometrist or orthoptist. The melanomas shown here are choroidal, and these are the most common primary intraocular malignancy in adults. 90% of uveal melanomas will actually arise in the choroid, and about 5% per million people per year will develop a choroidal melanoma, and that's actually quite a few people. It affects males and females equally, and what you notice is an elevated subretinal dome-shaped mass. And the reason that it's subretinal is because it's in the choroid, and the choroid actually sits under the retina. So here is a pigmented choroidal melanoma, and it looks elevated because it's pushing these retinal vessels and distorting them. The melanoma down here is what we call amelanotic, and that's where it's not pigmented, and it's a dome shaped again, and it's just like a little ball pushing the retina upwards. So what they actually do, these melanomas, is they penetrate the Bruch's membrane of the choroid and the retinal pigment epithelium, and they herniate into the subretinal space, and they will invade the scleral channels that are there for blood vessels and nerves to pass through. And because they're in this zone, they can very easily spread around the orbit. They will eventually invade the vortex veins, and once they're in the venous system, they can metastasize and spread to the liver, and sometimes they can also spread to the lungs and the bone and the skin and the brain. So they can be quite nasty if they become metastatic. The next lesion that I'll tell you about is what we call a chirpy. Now, chirpy stands for congenital hypertrophy of the retinal pigment epithelium, so chirpy for short. And these are a very common benign lesion as opposed to a choroidal melanoma. And so they look quite similar, but these are found in the retinal pigment epithelium as opposed to the choroid. And they don't tend to spread or metastasize. Now, they can be either solitary, as you can see the ones shown here, or they can hang out in a little group, in maybe 2 or 3. Oh, this one here has got a little group of them, but these two are solitary. And they can also be what's known as typical or atypical. So a solitary chirpy is flat, and it's usually dark grey or black, and they can be round or oval, as you can see in these ones here. they have discrete margins, and that means that if you were to take a pencil and try and draw around the margin, it's quite clear where the chirpy margin is. So this is quite different to a nevis. The nevis tends to have more feathery edges. Sometimes they can also be depigmented, like the one in the top image, but usually they're dark colour. This slide here is showing you a grouped chirpy, and they are multiple lesions which are arranged in a pattern, and usually just in one area of the fundus. So the pattern simulates animal footprints, and so we sometimes call this bear track pigmentation, like that. So it looks like a little bear has walked across the retina. If the bear tracks or the chirpies are depigmented, as it is in this image below, then we call this polar bear tracks because they're white, as opposed to ordinary bear tracks, which are the dark pigmented lesions. So smaller spots tend to be located more centrally, and as I said, yeah, they can be depigmented completely, but this is less common. You're more likely to see these bear track pigmentation chirpies if they're in a group. So let's take a look at choroidal tumours now. So we've already talked about choroidal nevi, and we've talked about choroidal melanomas. So in this section, I'm going to tell you about hemangiomas, melanocytomas, and metastatic tumours. So we'll start with these choroidal hemangiomas. These are vascular hemangioma, we call them, and they're present in two distinct forms. They can be either a discrete or a diffuse form. Patients will usually come to the clinic in their 40s or 50s, and they'll say that they've got blurry central vision and will present with a central visual field defect and metamorphopsia, which is when you have distortion of straight lines. And they'll also have hypermetropia if the retina is elevated by either fluid or the tumour. Sometimes they can be asymptomatic. And what you'll see if you look into the eye is this oval mass with indistinct margins, and it's just there, it's just under the macula there. And it's the same orange colour usually as the surrounding choroid, so it's a little bit tricky to see as opposed to, for example, a choroidal nevis. And this choroidal nevis is actually considered this choroidal hemangioma is actually considered a discrete hemangioma because you've got one and it's just sitting there solo and it's only in one zone. A diffuse choroidal hemangioma will affect over half the choroid, and so it's all around here. There it is there. It's quite hard to see. What you notice is that the fundus is very deep red in colour, and these hemangiomas, diffuse choroidal hemangiomas, will enlarge slowly over time, and they will only occur in patients with a condition called sturgeweber syndrome, which I'm going to show you in the next slide. Sturgeweber syndrome is a congenital condition where patients develop benign tumours of the brain, the skin, and the eye. And what happens is they get this port wine stain, which extends over the area corresponding to the distribution of one or more of the branches of the trigeminal nerve. And usually the patient has a lesion which is unilateral. And you can see this lady here has got the port wine stain over the left side of her face. So it's these branches of the trigeminal nerve that have been affected in her. And then this fellow here has got the same thing. It's on the left-hand side. So usually they are a unilateral lesion, and they are associated with these choroidal tumours as well. Let's move on to melanocytomas. Melanocytomas are heavily pigmented tumours, and they're dark brown or black in appearance, and they have feathery edges, and often they're located within the nerve fibre layer. and they can be either elevated, as is this one, or flat. So if you see a dark area around the optic nerve, the retinal nerve fiber layer being affected, you can assume more likely that it's a melanocytoma as opposed to, say, a chirpy, for example, which kind of looks similar, or a nevis. So they're always found around the optic nerve head, and they're actually more common in dark-skinned people and more common in females. These can also arise anywhere in the uveal tract, not only at the choroid. Now, the choroid is the most common site for uveal metastases to occur, and it accounts for 90% of tumours, the location of the choroid. Now, usually though, metastatic tumours are overshadowed by the patient's general illness because they're a secondary condition to, for example, breast cancer, which commonly occurs in women, and lung cancer in men. And the patient will complain of decreased visual acuity, usually only around the macula. And you'll find that these choroidal tumours are fast-growing, creamy white lesions and can have multiple sites. And both eyes can be involved in up to a third of patients. And what happens with these tumours is patients will commonly also develop a retinal detachment. And the final tumour in this presentation is a retinoblastoma. Retinoblastomas occur in 1 in every 17,000 live births, so they're fairly common, and they are the most common primary intraocular malignancy in children, and they account for 3% of all childhood cancers. And what happens is they grow into the vitreous or the subretinal space, and they seed tumour cells throughout the eye, and they will cause a retinal detachment. They'll then seed into the optic nerve and eventually spread to the brain, and will have diffuse infiltration into the retina, so they'll get into the retinal spaces too. Eventually, they'll metastasize and go into the lymph nodes, the lungs, the brain, and the bone. So they can be actually quite fatal. So early detection and treatment is of utmost importance. So the top image here shows orbital inflammation, which can occur with retinoblastoma, and down the bottom here, this poor young child's actually had orbital invasion. You can see the tumour's grown quite badly around that eye. Usually they're detected pretty quickly, so it's unlikely that you'll see a patient at this stage, but you may well certainly see one with just the inflammation. So what signs and symptoms should you look out for? Well, the child will come into the clinic usually in their first year of life, or maybe second year, depending if the condition's bilateral or unilateral. And leukocoria is noticed firstly, and it's found in about 60% of cases. And that's this abnormally white reflex out of the pupil. Now, this should be red because you get a red reflex as the choroid is shining nice and brightly back at you. However, this isn't the choroid, the whiteness, it's a tumour. So this is the first sign that's noticed. And about 20% of children will have a strabismus, an eye turn, in association with their retinoblastoma. They also sometimes develop secondary glaucoma, which is shown in the image at the bottom here. And retinoblastomas are treated with chemotherapy, cryotherapy, or enucleation. And as I said previously, they need very fast treatment before they metastasize to the rest of the body. And when they do, they can be potentially fatal. Okay, so we're coming to the end of this presentation on tumours, and let's just go back and have a look at them again. So tumours can occur in the iris, ciliary body, the choroid, the retina, and the retinal pigment epithelium. Of all these tumours, it's a good idea for you to have a good understanding of the differential diagnosis, particularly between you should understand iris nevis and iris melanomas and ciliary body melanomas. Other tumours that you should have a good understanding of are choroidal nevi and choroidal melanomas. And the other one that is a good differential diagnosis to understand is the difference between a chirpy, for example, and a choroidal nevis. It's very important that you know how to differentiate between these two.